guys, welcome to the Modern Woman's Podcast. And we're back this week again with Nick and Elizma. Hi guys, how are you going?
Oh,
Dan?
very good. Thank you, Dan. Very
good.
Yeah.
And we've been having a little bit of a chat and planning for this podcast this week, guys. And I think we've come up with a really good topic and one that I think a lot of women will want to hear about. But I think we're going to as well jump in today and debunk some of the things around thyroid function.
Yes.
And what we're seeing with our patients, what roles the thyroid has in the body, but also then going beyond the classic signs and symptoms. So I think it's going to be a lot of fun.
Oh,
It'd
definitely.
be great fun.
Yeah.
It's a very big subject.
It is.
Yeah.
It is. So I think if we get started, guys, and really just jump into some of the more simple classic signs and symptoms, thyroid function as a whole, speak about what its roles are in the body, and then we can start to get into some more of the fun stuff.
Absolutely.
Yeah.
What I'll start with is just to kind of give a really quick explanation about how the whole cascade, the thyroid hormone cascade work. So essentially what happens is your thyrotropin releasing factor gets released from the hypothalamus. That stimulates, and this is parts of the brain, and that then stimulates the pituitary gland to release TSH, thyroid stimulating hormone, which is typically what doctors would test for if you go and get your thyroid tested, is that TSH. But remember, TSH is it's a brain hormone. It's not really actually a thyroid hormone, because that gets released by the anterior pituitary. And then that TSH communicates with a thyroid gland, where it then stimulates the thyroid gland to produce T4 and T3, T4 being the inactive thyroid hormone, or sometimes also called thyroxine, and T3 being the active thyroid hormone. And it's the active thyroid hormone, that T3, that does all the jobs in the body, cellular function, carbon, fat burning, all of those kinds of functions. But that's just kind of like a quick summary of how it works from the brain down to the thyroid and how these hormones are being released.
Yeah. And so we may as well start with some of the common signs and symptoms that we get, and then we can move into some of maybe not so common, because there is a lot of not so common ones that we see, particularly in clinic. So, I mean, your classic ones when we're talking hypothyroidism, which is underactive thyroid. So your classic ones can be weight gain, constipation, cold, fluid retention, hair loss or thinning hair can be some big ones as well. So, yeah.
So what are some of the more uncommon ones with low thyroid? Because we're talking now about low thyroid function.
Low thyroid function.
So what are your more uncommon signs and symptoms of low thyroid function beyond the weight gain and the puffiness and all of that?
Well,
look, we both wanted to bump in there.
I think that one of the biggest ones for me is depression or low mood can be a really big one that people may not associate with low thyroid function. So that's a really big one for me. Not sweating. So if you find you're going to the gym or you're exercising and you're not really sweating, that also can be a really good sign as well. That's a little bit more unusual.
Yeah, definitely, Nick.
And I think you talked about like low heart rate as well.
Low
blood
heart
pressure.
rate, and low blood pressure are other signs that we see a lot.
Absolutely. And what about even things like poor wound healing, brain fog,
Yeah,
those sorts
actually.
of things, so even cognitive function being affected there. And I know, Nick, we were speaking about before as well with even conditions such as fibromyalgia.
Yes.
So that could even be something tied into potentially hypothyroidism as well.
Yeah.
Carpal tunnel syndrome is another one.
Yeah.
Oh, yeah. I didn't think about that one.
Yeah.
So there's people getting carpal tunnel surgery, and if they looked at their thyroid and started to work on their thyroid, they may not have had to have that surgery. So it's good to do some full investigations.
I think there was a kind of an unusual one we kind of touched on before, hoarseness or changes in the voice, right?
Voice.
Yes.
Yeah, because obviously your thyroid wraps around your vocal cords, and so if it's enlarging or it's becoming inflamed, it can affect those vocal cords. You get a raspy voice or even a lower voice as well.
And that's the thing. I think we even just we often need to educate our clients on where the thyroid is, isn't it? So and that's where I've seen it more and more when speaking to my clients. If we have that potential that hoarseness, that dryness, even a sore throat that comes and goes, is that maybe a sign as well of something going on with the thyroid, maybe some inflammation there, something that's happening there, that if it's not something that we can diagnose from whether it's an immune picture, do we start to look into the thyroid that way as well? So
yeah. And that makes me think a little bit more esoterically when we look at what the throat kind of presents is that kind of speaking your voice and things like that. And I'm sure a lot of women out there can identify with feeling like they can't say what they want to say or what they need to say, or feeling stifled in their voice and their expression, right?
Yeah, definitely. That's a big one.
That's a big one. I think we see that a lot. I mean, even personally, I know that as well. So, I really like that, Elizma. That's a really good point.
Yeah,
all right, so that's low thyroid. Now, what about more common signs and symptoms of hyperactive thyroid?
Yeah. So hyperactive thyroid, which is speeding up of that thyroid function. So we can see weight loss. Pretty much the opposite of everything we've just said. So weight loss, excess sweating, it's extreme hunger because you're producing a lot of stomach acid, loose stools can be another one as well, greasy hair, greasy skin, that sort of thing can be...
irritability, nervousness, those sorts of feelings,
I've got a funny one here, smooth velvety skin. Which I thought was interesting.
I'd love to have smooth velvety skin.
I know. Not if it was hypothyroid though, really, Nick?
No, probably not. I mean, you get a dry skin with a hypo, so apparently, more thinning or smooth velvety skin is what I kind of found when I was researching this a little bit, which I thought was kind of interesting.
I think they need to change that description because what is it?
Smooth velvety skin
sounds really great.
I know, it does, doesn't it?
I'd say something like oily
condition,
that we want.
Yeah.
If I don't want to be
maybe
hypothyroid.
it's not the best description. But then we also have the obvious eye signs, don't we? So with the hyperactive thyroid, you get that kind of bulging eye look, which you find in Graves' disease. And then in low thyroid, you can get the thinning of the eyebrows. And I think you mentioned earlier, Nick, the drooping eyelids.
So drooping eyelids. So you find that you won't be able to open your eyes all the way up. So you find so that can be, again, the opposite. So the fast is the eye pop, sort of, and then the other is sort of that the heaviness of those eyelids. So
all right. Cool. So that kind of that I'm sure a lot of people out there, a lot of women out there can identify with some of these symptoms, which may indicate that there may be some thyroid dysregulation. And we have so much to talk about today. And I think what I'd like to just kind of get into before we go into all of these other mechanisms is getting people to understand that the thyroid, when the thyroid starts to become dysregulated, it's very rare that it's a primary condition. In most conditions, it's a secondary condition, meaning that there's something else going on that is making the thyroid respond in the way that it's responding. Because the thyroid, a little bit like the mitochondria, has to regulate a whole bunch of cellular processes. And so there's mechanisms in place where if something happens, if there's a stressor, and this could be emotional stress, physical stress, environmental stress, the thyroid will make things go higher or lower and start to change a whole bunch of cellular processes in order for the body to accommodate to the stress. So I always like to look at the thyroid as well, not treat the thyroid as the thyroid gland, but look at what is the thyroid doing and why is it doing what it's doing, and then find out where that mechanism is and kind of get back in, kind of look at that. And the reason why I want to kind of explain that is because we're going to get into some really cool areas where thyroid function is involved and where it can become dysregulated. So what is one of the most common things that you guys find that starts to throw this thyroid gland out that a lot of people can identify with?
Stress would have to be the biggest one.
Absolutely.
Big one.
Yeah, definitely, Nick. And I think also then in conjunction with that, and we can talk about this further, but I know we were all speaking about this off air, and the number one cause of any sort of thyroid dysfunction in Australia, and I know that's a statistic that we've all researched, is autoimmunity. So if there is any sort of autoimmunity at play, we know that's probably the primary starting point before thyroid dysfunction. And this is where sometimes when we do thyroid testing, and we'll get into that it may not show up in terms of TSH being elevated or lower, potentially hyperthyroidism in any way. It actually is, we have to look at the other markers first, because there's probably something going on with that autoimmune type picture. So
yeah, very, very well said. And what's the kind of stuff that can kind of trigger off autoimmunity or the formation of antibodies?
Well, I mean, stress obviously is a big one. Gut permeability is a really big one as well. food allergies, chemical sensitivities as well can be a big one as well.
Infections, all that kind of stuff, yeah?
Yeah.
All right. So in terms of stress, so when we're talking about stress, we're talking about obviously mental, emotional stress. We're talking about, and that could be like bad relationships, stress with family, stress with kids, stress with job losses, which there's a lot of at this point in time. It can also be physical stress like overtraining or not sleeping enough. And then it can be environmental stress, which is the toxins and the infections and the stuff involved with the antibodies,
Yeah.
Also nutrient deficiencies is a
big one.
Actually, I mean, because in terms of the nutrients, like what are the kinds of the main nutrients that we need for thyroid function?
Well, the main ones are iodine, zinc, tyrosine and selenium. They're the four big ones. But then we also need a lot of other ones. So we need vitamin D, we need B12 and folate are really important as well. So, and iron.
Iron is a big one.
Big one.
Vitamin A is another one, I think, inositol and copper as well. So, but you're right. I'd agree with you. Like the four main ones, probably tyrosine, zinc, iodine and selenium. All right. So, in terms of getting all of these nutrients, I mean, tyrosine is an amino acid, as we know. So, where do we get tyrosine from?
Protein. Yeah, and what do we need? Shall we expand? Let's expand that. Yes. I mean, I guess that there's a problem comes into when we see digestive dysfunction. So being able to break down and absorb those amino acids as well can be a problem, and that's when we see the deficiencies arise a lot of the time.
Yeah. And isn't it interesting that stress can reduce stomach acid, which can then reduce absorption of tyrosine, which then throws your thyroid out, right? So you take a lot of that stuff back, right?
Yes, that cascade there.
And then we've got the iodine, which is probably a little bit harder to get because I think you guys said, iodine, selenium, most
very depleted.
Depleted.
Yeah, in Australia, particularly selenium. We have very low levels of selenium in our soil in Australia, and we don't have a lot of iodine either.
And also, what I was reading into as well, our dairy products, there's a declining iodine content in those as well.
Oh wow!
So that's something just to be mindful of. Obviously, when we start to look at dairy as a whole, is it something that someone might need to remove from their diet? And yes, we can get iodine from other areas, but even as our progression in the last few decades, is this something that we're just naturally getting less and less from a standard diet? So we're not getting it from our soil in adequate amounts, we're not getting it from dairy products, and also then even things like sodium, so our salt consumption. So is this where then things like the iodized salt is coming into play as well?
And also seafood. A lot of people aren't eating as much seafood as they used to, and also our seafood is so contaminated these days as well. So there's other sources that we're really shying away from, and from a health perspective that there is issues with that as well.
Yeah. I'm glad you mentioned the seafood because when I was doing research a couple of years ago, I found that we think of fish as fish, but there's a huge difference between the iodine content of freshwater fish and seawater fish, and it was quite dramatic. Like I can't remember, I think I got the exact number somewhere here. But something like 3 micrograms per 100 gram in freshwater fish, where it was 300 micrograms or milligrams. I think it's micrograms. So a huge difference, like of up to 100 times differences in iodine levels. So I mean, I don't know how many, the types of freshwater fish, but if you just eat freshwater fish, you're not necessarily going to get that iodine content.
And then if you are eating the ocean fish, you've got to watch what you eat because those larger, longer living fish are high in mercury. And then we can talk about heavy metals and how they affect thyroid function as well.
Mercury is a huge one with the thyroid.
So that comes into play.
And that mercury is exacerbated if someone already has a selenium deficiency, isn't it? So we see that connection.
So we're going to get deep into that stuff. I think that's a very good kind of about the glutathione and all of that. I think one of the things whilst we're on iodine, I kind of like also want to kind of mention to people out there is we just think of iodine as iodine, but actually when we consume iodine, it's in the form of iodine, but in the gut, our gut bacteria actually has to convert that iodine into iodide. So you need good healthy gut function to kind of get that conversion happening because it's in the iodide form that it gets into the thyroid cells. And then once it's inside the cells, then it converts back to iodine again. Now, when you because food fortification is a big thing these days, not just in folate, or I should say folic acid, which is synthetic, but also in iodine. Now, the problem is that the form of iodine they use in the fortification of food is in the iodate form. And the iodate form has to use glutathione in the gut to be converted into iodide. So that means that, because glutathione, great antioxidant, very important for detoxification. So if you're using up a lot of glutathione in the gut to convert this fortified iodine, that means there's less glutathione available for the gut cells to protect them against oxidative stress from food preservatives and, bad gut flora and all of that kind of stuff. So it's important to understand where, the food minerals or food nutrients as opposed to fortified nutrients.
I love that point, Elizma. And I think also then we start to look into other things that affect the uptake of iodine as well. And I know we touched on before, guys, particularly the halogens. So to give people an insight into those being fluoride and chlorine. And we get those often in our drinking water if we're not filtering that. And then even in terms of things like toothpaste. So also as well for people that maybe do a lot of recreational swimming, that chlorine content as well, is that something that exposure is now also having an impact on iodine status in the body and then thyroid function overall. So,
absolutely, the fluoride one is definitely a big one because it's not just in toothpaste now. I mean, a couple of years ago they started adding it to the water as well.
Exactly,
water in Queensland. They didn't have it, up here. They've had it in the rest of Australia for a long time, but they didn't up here. But
that's right.
It's now in Queensland water as well. So not mass medication, but that's for another.
My thing with things like that, and it doesn't matter, what you put in the water, or even fortification of food, right? So the problem is you can't manage the amount that people ingest. Because you're going to get one person who drinks 1 liter of water a day and another person who drinks 3 liters of water a day. So they're going to get a whole bunch more in, right? It's the same with bread. When they started fortifying bread, I'm like, well, that's very nice if you eat just 1 or 2 slices of bread. But there's people who eat a whole loaf of bread a day, right? Yep. So you lose control of how much people are consuming. And that's where I more have a problem.
Yeah, definitely.
But that's off the topic of thyroid.
For another
so we'll get back on the topic. So other nutrients like selenium and what was the other one? Zinc.
Zinc's a huge one.
Yeah, definitely. And I think we start to look in terms of why we need adequate zinc. So that conversion of T4 to T3, so from that inactive to active form, looking into supporting the receptors as well at T3. So this is the other thing, we can get into this, but where is that the receptors are being affected by those external factors as well, whether it's toxins, chemicals, anything like that. Also stresses, poor digestive processes, but also can we start to bring in that conversation of where is our T3 being replaced, or I guess we can look at the opposing hormone that's produced, which is reverse T3.
Which is a big one because we, obviously we're all in clinic, so we see a lot of thyroid panels.
Yes.
And a lot of doctors saying, no, everything's fine. We've even checked your T3 and your T4, which is not that common these days. So and everything's within range. But without checking that reverse T3, we can't see what else is going on there, and that's generally a huge problem for a lot of people.
Absolutely, because it's kind of like cortisol that kind of creates that conversion, isn't it?
Yes.
And cortisol comes from inflammation, stress. Not sleeping enough, all of that kind of stuff, right?
So cortisol will block the conversion of T4 to T3. It'll actually convert it from T4 to reverse T3. So reverse T3 is a very inactive form of T3, and it's essentially a mirror image of T3. So it'll fit into the the T3 receptor upside down.
That's right.
And it'll actually block the actual T3 from going in, but your body doesn't know that it's not an active form of T3, so it won't produce more T3. So then that's when we start to see that hyperthyroidism.
So it'll think it'll have enough, right?
Yes.
So it thinks it has enough T3, but there isn't really. So it's a mixed message kind of going on in the body.
And it's like that constant competitor, isn't it? So at that cellular level, that reverse T3 is then being produced in higher and higher amounts, and it's starting to compete exactly as you said, Nick, at that site. So and also too, I like that, Elizma, with what you touched on in terms of the stress being quite a huge factor there. I don't know if you guys have seen this with your clients as well, but where we start to see a calorie restriction and also carbohydrate restriction in women. Is that something that's also starting to shoot that reverse T3
huge. Because what happens when we stop eating is our bodies will, your blood sugar levels will drop. Your body will be like, I have to make more sugar for the brain and for everything else. So it'll start breaking down your muscles through through a process called gluconeogenesis. Now, in order to get that process going, you have to pump out more cortisol. So you pump out more cortisol, you break down your muscle, blood sugar goes up, and that's all great, but now you've got so much cortisol, it inactivates your thyroid. So this is where starvation, for all the women out there, it's not the best way to lose weight, because in the long run, you will affect your thyroid function, slow down your thyroid function over the long run.
Yeah, definitely.
Overtraining, I think, would do that as well.
Overtraining is a very big one, and I see quite a few clients that do that, and myself have done that in the past and ended up with a lot of thyroid issues there. So, overtraining is a huge one, because again, that pushes up your cortisol, which brings it back to that mechanism of blocking that T4 to T3 conversion. So, huge. And starvation as well can not just be starvation is in not eating. It can be particularly carbohydrates as well. So that's still starvation in a way. That's a lot of nutrient deficiencies there as well. So, I get a lot of women that say, no, I eat a really balanced diet, or I eat enough calories. Well, for one, they don't most of the time. And two, they're not having any carbohydrates, so they're having minimal simple carbs, so your fibrous vegetables, but they're not having those starchy carbohydrates, and then we're seeing a lot of the issues with that as well.
Yeah. All right. And then also, interestingly, we were talking about zinc and selenium, and probably one of the richest food sources would be nuts and seeds. Is that right?
So particularly Brazil nuts for selenium. So that's the highest. So. And selenium is needed. So the selenium is in the greatest amounts in your endocrine glands, particularly your thyroid. So selenium is very important. So, but getting enough is important. But then, if you sit down and eat a whole bowl of Brazil nuts, that's probably not the best idea either.
No, I used to do that. I think I went through a stage during my pregnancy where I just craved Brazil nuts, and I would eat like a whole pack of Brazil nuts every single day.
Wow.
Now, I don't know what they did to my children. I'm sure it probably wasn't a good idea, but
I'm sure there could have been worse things.
Probably could have been worse things. All right, so that's kind of like goes into some of the nutrients. Now, what about anti-nutrients? There's a lot of information, some misinformation about anti-nutrients and thyroid, about foods that you're supposed to avoid. So let's talk a little bit about that.
Yeah, Nick?
Well, goitrogens are a big one. It has been around for a long time. So goitrogens are things like your brassicas, so your broccoli, cauliflower, Brussels sprouts, that sort of thing. Soy as well, peanuts. They're
peanuts too.
Peanuts as well. Yeah. So that can be an issue, because again they block thyroid function. So slows down, block iodine function. So it can slow down your thyroid there. And so a lot of people will actually avoid goitrogens altogether when they have underactive thyroid, and that's also not a good idea, because we still need those nutrients from those foods. They're still healthy foods. So even lightly steaming the vegetables can inhibit that goitrogenic activity. So
so it's the cooking or the preparation can change the food from being a potential goitrogen to being good for the thyroid and for our health. Definitely. So that's like light steaming of vegetables. What about fermenting? Like, cabbage is another brassica. So, when we ferment it and it becomes sauerkraut, that will probably change it as well.
Yeah. And definitely in terms of the digestive processes then used as well, Elizma. So to break that down, if we think about, the raw food type movement that's sort of swept through at one point, and maybe some people are still in that. But if you then, what I like to look at from that goitrogens perspective is, well, how much are you eating across the board, but how much of it is raw? So can we just change that? Can we swap out that raw, say if you're having lots of raw kale, for example, which I know a lot of people were doing for some period of time in smoothies and things. So can we swap that out for something else, or just make sure that if you're having kale, you're steaming it or cooking it or preparing it in some other way? So you're not having that complete goitrogenic compound that you're consuming. So and soy is another one. So the phytoestrogens from soy is a huge one. So
soy has a lot of problems for a lot of different reasons.
It does.
But definitely the goitrogens is one, which is why if you are going to have soy, you're better off having that tempeh, because it has been fermented.
Right. So we're talking about raw soy, like soy milk.
Even tofu.
Tofu.
So soy milk would be like a raw soy. So that's what you would want to stay away from, right? But the miso, the tofu, the tempeh, that's the fermented form. So they should be a lot better to use. Even when you're looking at milks, if you are, a little bit of soy is okay. You just don't go on
not want to go overboard.
Moderation.
But if you're looking at, always look for products that have whole soybeans, not the soy concentrate. Look for organic whole soybeans and that's really a better option, particularly with milks and things like that.
And so when you're talking about supplements, because a lot of supplements out there like our NRF2 activators that's got broccoli sprouts and stuff like that in there, that shouldn't be a problem with the thyroid, should it?
No.
No.
No,
Right.
they've done a lot of research on all of that, and it really is. And you have to consume a lot to have that effect.
All right, good.
So let's get that off the table.
Exactly.
Let's
we still
that.
want the broccoli sprout in there, 100%.
Absolutely. No, well, I'm a big believer that sprouting also changes, you know. So when whatever it is you're sprouting, whether it's fenugreek or broccoli or alfalfa, it changes. You're liberating a lot of enzymes, and it's not necessarily exactly the same as the plant itself. Yeah. All right, good. So that's kind of like the things that would potentially interfere with the thyroid. We've looked at some of the nutrients that's very important for the thyroid and how we need that. Something that I think is very interesting, and Nick, you kind of like said it in the beginning when we looked at the symptoms of low and high thyroid, is that one of those symptoms is constipation with low thyroid. And, you know, a lot of women with thyroid issues do have irregular, I guess, bowel motions. I find constipation a very common symptom with those with low thyroid. Now, there's a very interesting association between the thyroid and bowel motions, which would explain why women with low thyroid would experience constipation. That's because the inactive T4 hormone is actually needed to, I can't remember if it is it was some kind of a sphincter, the Odie sphincter, that's right. So there's a sphincter of Odie at the gallbladder, and it needs T4 to kind of bind to receptors, and then that bile duct kind of dilates, and then it allows bile from the gallbladder to get dumped into the small intestine. And our bile is like our natural laxative. It kind of cleans everything out, and it also kills off a lot of harmful organisms like, not harmful, but things that overgrow, that shouldn't be overgrowing, like candida and other organisms in the small intestine. So very important for thyroid hormone to regulate that gallbladder function, which is needed to help and prevent SIBO, small intestinal bacterial overgrowth, and keep the bowels moving. So we often just think of thyroid as just thyroid.
Yep.
But it's just, we can see that it's just so much more than just that.
It does. It affects so many different functions in the body.
Yeah.
And then that's one of the first things that we say to clients is we ask them, you know, how they're digesting their food, if they're bloating, whether they are having regular bowel movements, because then we can see that they maybe are having a little bit of gallbladder insufficiency, low stomach acid. And so, you know, even things like just adding particular foods can really help with that as well. So your bitter foods can really help there as well.
Yeah.
So food as medicine comes into play again there.
Always
Absolutely.
is, isn't it?
Yeah. I think that's the thing, though. We have to remind ourselves that where the thyroid has such an impact and a widespread impact on the entire body. So there's so many different processes that whether we are producing too much or too little of those thyroid hormones, or now we throw in the thyroid antibodies, so someone is having that underlying immune reaction simmering away there without us realizing it. That impact is systemic, isn't it? So it's so widespread, and I think every time we see our clients, because there's so many complex moving parts, there's so many symptoms, we have to keep asking the question, well, what's the thyroid's role in this, isn't it? You know, so what part is the thyroid playing here? Is it the main thing? Maybe not, but it's still having an impact in some way.
Well, absolutely, because I mean, we often forget that all the cells in our body has thyroid receptors, right? And so receptors, I always try to explain to my clients, I see receptors as a little bit like the old hungry hippo thing. So the receptors are like the hippos, and then the little balls that they're trying to eat is the hormones or whatever else it's supposed to attach to it. So in this example, your thyroid receptors are the hungry hippos, and the thyroid hormone, or that T3, is the little balls that it's trying to catch, right? But we have those little receptors on all the cells in our body. I mean, T3 thyroid hormone is what makes our mitochondria work as well, right? So a lot of people, you know, we talk about mitochondria, and that's great, but the thyroid hormone kind of like makes that work, which is where we burn our fat and our carbs and produce energy. And all the cells in our body needs this energy, the immune cells, the brain cells, the kidney, the liver, everything. My partner asked me an interesting thing because, you know, when we drive together before these podcasts, I always yabber all my notes down. You know, I tell him, oh, we're talking about blah 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 blah, and he's like, okay. So what happens if you don't? Can you live without a thyroid? And I kind of thought about that, and I thought, well, yeah, but you have to take thyroid hormone, right, for the rest of your life. He says, okay, what if you don't take thyroid hormone? And I said, well, no, I have not researched this, but I said, I'd expect you'd probably die because I can't see it just affects so many processes that'll just stop if you did not take a thyroid hormone if you have to have your thyroid removed, right?
Exactly. And I think then, okay, so then even for people that don't have a thyroid or they've had partially removed in whatever way, and we see that with patients, definitely. Say you are taking that thyroid hormone, you have to then be doing the other things that will still support that conversion of that hormone that you're taking. So even though it's an external, you know, medication, you're taking the T4, the thyroxine, you still need to have those other cofactors and things in place and make sure everything else is functioning for that to be converted forward. So you're only getting half the way. And how often do we see that? People that are taking, for example, they've been on thyroxine for a period of time and their symptoms are worsening, and then their labs are also, their pathology labs are changing as well, so they're not improving. So we go, well, why is that? It's not the magic pill in a sense.
And the thing is, one of the most common things is we're not converting T4 to T3 effectively. So if you're just pumping in more T4s in with thyroxine, it's not going to do anything if you still can't convert
Exactly. And even if you take the T3, because you can get different forms of thyroid, right? Even if you take the T3 and that cortisol or stress is still going on, you're just going to inactivate it, right?
Exactly. It goes back to the reverse T3.
Yeah.
Exactly.
And one of the things, because my mum, you know, she's been on thyroid medication since I was a little girl. So she's been on, you know, she probably will never be able to get off it, right? And I've seen her, you know, every 2 months almost having to go to the doctors, getting levels checked and adjusting medication. And that's because the thyroid is a little bit like the mitochondria. It fluctuates so many times over the day depending on what you eat, what's going on. So to try and micromanage a thyroid gland with hormones is almost impossible, right?
Well, I mean, your thyroid there's something affecting your thyroid for it's doing something, it's becoming underfunctioning or overfunctioning for a reason. Like any other, issue that in our body, like we just said, it's one whole machine, it's not parts. So it's telling you something. So instead of just putting a Band-Aid over the thyroid with some thyroid medication, you need to address the underlying cause. Yeah. And like you said, Elizma, when people go on to the thyroid medication and they're on it for a long time, it's really difficult to get off it.
Yeah.
So you want to try and avoid it as much as possible. Obviously, sometimes, as Dan said, you do have to have it. But if you can avoid it and look for the reasons why your thyroid is becoming imbalanced, then that's the better option, and stay away from the medication if you can.
I think we talked a little bit about ourselves before this, and now we've had our thyroids checked in the past, and it wasn't always so healthy because of whatever lifestyle choices we made at that point in time.
Yeah.
But all of us, have managed to kind of get those levels back in regulation. The TSH levels, which typically, if we followed typical advice, we would have been put on some kind of thyroid medication. But through changing, lifestyle choices and getting stress under control and all those things, we've managed to kind of get our levels back into much more better places without the use of medication. So medication, I guess, and obviously you have to talk to your practitioner, your doctor about this, but I always look at it as the last resort. First do all the basic things, make sure you get all the nutrients for the thyroid, make sure there isn't any interferences, make sure it's not diverting to other pathways. And sure, if you've done everything and it's not working, then maybe medication is the next step. But
and maybe we could even talk about what the medical profession do, and for our own experiences, when before we were all obviously practitioners and didn't know as well as we do now. And we go to the doctor and what we what advice we were given and what we were prescribed, and how common that is when we see clients that come to us for that as well. So a lot of times it is just thyroid medication, or the more common thing is there's nothing wrong with you. So it's amazing how often that happens. And even from my experience when I was competing and overtraining around that time, and my thyroid was very suppressed, so severe hyperthyroidism. And I had, which is quite funny, the doctors gave it a name. So I had like a choking sensation in my throat, and I had it for about 6 months, and it was to the point where it caused me so much anxiety and stress because I thought every day I was just going to choke because it was that severe. And I went to doctor after doctor, and they said, no, there's nothing wrong with you. And I went to an ENT, and he diagnosed me with globus hysteria. Was that's
a very big name.
That's right. And I said, what's globus hysteria? He said, hysterical. Essentially, that's what he said. The reason they call it that is because you are hysterical about something that isn't there. That was how he described it to me. And I said, but I'm living with this every day.
So it's in your head, is it?
It's all in my head. And obviously, in hindsight, I can, know clearly it was my thyroid enlarging and becoming inflamed and obviously pushing back in my throat. But that's the attitude. And that was a specialist that said that. So many women come up against that.
They do.
The doctor said, no, you're fine. Yeah. They're not looking at the symptom picture. They're not looking at listening to what the woman is saying, and they said your blood markers are fine, so you're fine, just go away and you'll be okay.
But that's also it too, isn't it, Nick? Because we've got so many women that come to us and they say, I've had my thyroid tested and it's the TSH that's only being tested, and we go, okay, well, you haven't had your thyroid tested. No. Because that's not by any means the most comprehensive assessment of your thyroid function. And this is also too where, okay, what if some women don't have the classic symptoms that we described in the beginning, but we still suspect there could be an issue with the thyroid? We need to go and do that further testing. It's not a question of should we or shouldn't we. It's no, we need to. We need to see what's happening here so we can treat accordingly.
Absolutely.
And that then sets you on that path of going, we can see where this is having an impact on the rest of your health. But what are all the other moving parts in there as well? And I know, it's funny because whether we want to talk about like subclinical hyperthyroidism, so where, say, even our TSH is still within range. I had that experience myself. And I was saying before to Nick and Elizma, I around about 18 years of age, where I'd been through severely under eating, severely over exercising, very underweight, and presented to my doctor with some of the classic signs and symptoms, but definitely low mood. And I could really feel that in terms of my metabolism, weight gain, those sorts of things after being so underweight was not right. Something was not right. And so I had my thyroid tested, and of course they said everything's fine. And this was well before I knew anything about thyroid function or anything like that. I did a little bit of my own research, but I actually found my pathology results the other day from that time, and my TSH was 3.6. Now, for anyone listening, they might think, oh, okay, well, that sounds quite low, or that sounds within the range, because the typical range, I think it may have changed, but was it 0.4 to 4?
I think it's standard.
It would have been 5.
Yeah.
Yep. So 3.6, if it was on a scale of 5, they would have looked at the TSH and said totally fine.
Yeah.
But we know as functional naturopaths and nutritionists that that's definitely not fine. And there was probably so many other of my thyroid markers out prior to even showing up in a high TSH. And so that's where I could see, no, I definitely had a thyroid issue, and it wasn't caught at that time. And it wasn't until years later when I actually started studying nutrition and researching that myself and seeking actual naturopathic help that I started to get my thyroid back to where it needed to be.
The ideal range of TSH is kind of like between 1 to 2.
Yes.
Of course, this
1 to 2. Yeah.
And this will obviously change with children and all of that kind of things, but generally about 1 to 2.
Yeah.
Absolutely.
And the problem with, particularly in Australia, as Dan said, the range is, I think they've reduced it to 0.4 to 4 now. Yes. Some labs are still 4.5. Yes. And if your TSH is within range, they will refuse to test your T3 and T4.
That's right.
So, you could have as Dan said, 3.5 or 3.6, which to us is subclinical hyperthyroidism, but they say, no, you're fine. And so they refuse to do those other tests, which is where it becomes really frustrating for women and us as practitioners as well to get that full panel looked at.
So sometimes, if you really want to know what's going on with your thyroid and you can't get it done through the general medical route, you can you can definitely pay for thyroid panels, much more complete ones, and it's not really that expensive in the big scheme of things. So definitely, if anyone out there want to get a good idea, you can request it from a practitioner or a functional medicine practitioner, practitioners like yourselves, to get like a full thyroid panel done.
Yeah, there's always options.
That's right, because even when TSH is in 1 to 2, it's not that uncommon to see normal, even to our standards, perfect TSH levels, normal T4 levels, but low T3 levels, right? Yeah. And it's all about the T3.
And I'm seeing that more and more as well. And that's why even when, for example, I might have a patient who has a 1.3 as a TSH, in my mind, I still query that, going, they've got so many other symptoms that you need the full picture. And that's even where we were speaking about off air as well. Then where do we start to look into testing other things, whether that's urine iodine testing as well? Do we need to go that step and test the iodine in the urine and see what the iodine loading is, what's happening there? Even selenium, do we need to do, red blood cell selenium? Zinc, of course, testing those nutritional markers. So further than even a full thyroid profile, do we need to go further than
into the nutrients?
Vitamin D. Vitamin D is a huge one.
And then again, it comes back to those ranges as well in the medical.
Exactly.
I think what's the highest range? I think up to 80. I think is. I'm not sure
which one is that for
vitamin D. Well, is it now anything?
Was it 50?
50 is considered fine.
Yeah. So I mean, look, we're looking at 150 to 200 is ideal optimal ranges of vitamin D. So if they're in sort of 40s and 50s, they're severely deficient. And their doctors are saying they're fine. And then obviously we need vitamin D for immune function.
Yes.
So when we're looking at autoimmunity and we've got low vitamin D, there's implications there as well.
And then vitamin A is another one. So vitamin A has got to do with, I'm not going to go into complex biochemistry, but vitamin A is needed for the retinoid X receptors to which the T3 hormone kind of binds to. Now, both vitamin A and vitamin D, fat-soluble vitamins. What do we need for fat-soluble vitamin absorption? Gallbladder function. What do we need for the gallbladder to function? T4 thyroxine hormone. So it's a loop back, isn't it? It's everything influencing everything.
Yeah, it is. Yeah,
not just one thing.
Well, it brings me to as well, just a little bit of an offset, what I found as well with supporting my thyroid function, and whether it was potentially more of an immune response as well for me, and I know it is for a lot of people, as we've touched on the autoimmunity. From a food perspective, and I'm sure you two are seeing that link, what is the link with gluten and the gliadin specifically? You were saying before,
I think
Nick.
You've researched this.
So fill us in, Nick.
Well, the thing that frustrates me, because I see a lot of clients that we get to the problem, and a lot of times it's Hashimoto's. We have to go through a lot of testing, and as we've said before, they've seen multiple doctors, and their thyroid panel's fine, and they're getting their T3 and their T4 tested, and they're both fine. And this is something wrong. So then we end up getting their antibodies tested. So then they're either Hashimoto's or Graves', and their doctors have just put them on thyroxine, and that's it. And so don't change your diet, don't do anything. So with us, straight away gluten-free, particularly with thyroid autoimmunity. Yes. So the reason being, so the protein in gluten, which is called gliadin, has a very similar protein molecular structure to the proteins in our thyroid. So if we have particularly gut permeability, which we talked about earlier, which is a big factor in autoimmune conditions, and we're taking in gluten every day, it's going into our bloodstream, our immune system is attacking that on a constant basis every time you eat. It can then get confused because it's designed to target that particular protein molecule. It then seeks out what's going on in your thyroid and says, that's the same thing, so it'll then start attacking your thyroid. So which is why we need to take that gluten out. And so doctors will put someone on thyroxine, and they don't tell them to change their diet, and your thyroid is just constantly being decimated, and you're having to increase your medication up and up and up, and you're going to get to the point where your thyroid's completely destroyed. So gluten is a huge one, particularly in any autoimmune condition, particularly in thyroid autoimmune conditions.
Yeah, and I don't know about you guys, but and again, this is not about bagging anyone, but I've had so many clients tell me, when they come back, when they do have antibodies, and the doctor says, well, there's nothing you can do about it. And it's just like,
really? Or they're supposed to be there. Don't worry, we're all supposed to have antibodies, which is a great one as well.
Exactly.
And I don't know about you girls, but you can get those antibodies down.
Yeah, you can.
Even from very high levels, you can get those antibodies down.
And we see it all the time. I mean, there's so many things you can do to bring them down. And my goal is always to get them to zero.
Yeah,
so, that's the goal.
Yeah, you don't want to have antibodies.
No, we don't want those. No. We don't want them floating around at all. And that's it. It's exactly it, Nick. You have to switch off that immune system reactivity, because if that even on some small level is still there, and this is why I sometimes, I don't want to get on my high horse about gluten, but if we need someone to go gluten-free, it has to be 100% gluten-free. Yeah. Because isn't this what we're hearing often, that people are saying, I'm partially gluten-free, or, but if you've got an autoimmune condition, or, you have this thyroid dysfunction, whatever's going on there, if you've got that constant immune reactivity, inflammatory storm happening, you've got to take the burdens that are basically influencing that. If gluten is one of those things for you, if you are a celiac, obviously, but even if you're not, if you're someone that is now reacting to that gliadin in that way, Nick, we have to pull that completely out. It's not a matter of going, I'm half gluten-free, I'm half not.
Yeah.
No,
because we're not talking about allergies either, right?
That's exactly it.
You don't necessarily have to get an allergic reaction to know that you're reacting to gluten. It's kind of like an underlying reaction that you may not even really notice, apart from maybe some digestive discomfort or something like that, right?
That's it. So when people eat it, they're obviously not having that reaction as a celiac would, and they think, well, I'm not reacting, so it should be okay even if I have a small amount. Well, no, you can't see what's actually happening on that immune level, can you? So there's still some reactivity there. You've got to take that away.
It can take up to 3 months to totally eliminate gluten from your system. So if you're having just a small bit here and there, you're still creating that immune reaction.
I've even heard, and I don't know how true this is, but I've even heard that people who've gone gluten-free, usually in the case of celiac or whatever, like when they do colonics or whatever, like even 7 years down the track, they can still be like gluten proteins.
Wow.
Now, I don't know if that's true, but I just thought, wow, that is that's pretty
significant,
full on,
isn't
right?
it? Yeah.
It just goes to show you. So, I mean, a lot of people roll their eyes when they hear health practitioners say gluten-free, dairy-free, but there is scientific backing for this.
Yeah, definitely.
Yeah.
So talking about antibodies, like what are the 2 most common antibodies that can be tested for, and what makes them a little bit different?
So we've got the thyroid peroxidase antibody, so your TPO, which is what people might hear most of, then also your thyroid receptor antibody.
Or sometimes we call them TRAB. I always like the little abbreviations.
Thyroid globulins, I don't know, we've all got different things to say.
And the TRAB antibodies, that's usually more to do with Graves' disease or the hyperactive thyroid, right? And then the TPO antibodies, more Hashimoto's or the lower thyroid function. And I don't know about you guys, I see the TPOs a lot more than I see the TRABs.
Yes, yeah.
I mean, a lot of times they'll both be elevated in either, but generally your TPO more so is what you'll see. But you'll generally see them both. There is antibodies present. But it just depends if it's Graves or Hashimoto's.
And we talked about iron being so important. So iron for the TPO mechanism, right? That's a big cofactor.
That's a huge one that we talk about all the time, and probably one of the less known symptoms of hyperthyroid is iron deficiency. So when we see iron deficiency and there's no reason that we can find for that, we always look to the thyroid. And
that's so common in women, right?
So common.
So sometimes it's not that complicated. It's not about, some severe disease going on with your thyroid. Sometimes just because you're iron deficient, because you've got heavy periods or whatever the reason, right?
Yeah, I mean, I've had clients that are have amenorrhea, so they're not actually even having a period, perhaps athletes, things like that, and they're still iron deficient. They're eating meats, and they're getting transfusions, and they're having to have multiple transfusions, and then you have to question why you're not holding on to your iron, and investigate further there. And it's so common because why do we need iron for thyroid function and why do we need thyroid for iron? So, those thyroid hormones are needed for red cell production in the bone marrow to produce iron. So if we don't have enough thyroid hormone, we can't produce that iron.
Yeah. And so if you guys want to know more about iron, there is an iron podcast for ATP floating around, so where we really, really went into a lot of depth. So that's really important. Now I'm going to get to my favorite topic. Now that we're on the TPO antibodies, because glutathione plays such a huge role in the TPO antibodies, right? And I probably have the mechanism here somewhere, but I think it's got to do with hydrogen peroxide production. So if there is excessive amounts of hydrogen peroxide production, then that kind of like can cause these TPO antibodies to start to increase. Now, hydrogen peroxide, it sounds terrible. In plain terms, it's bleach. But our body actually makes hydrogen peroxide as part of our immune response. So whenever we have infections, viral, bacterial, or other, our immune system will make hydrogen peroxide as a way to kill off these organisms. That's why you feel so crappy when you're sick, when you've got the flu. It's because of all these free radicals like hydrogen peroxide floating around. But it's necessary to kill off these organisms. Now, if you have chronic infections that your body cannot get on top of, so it moves from an acute to a chronic stage, you're going to have this chronic production of hydrogen peroxide. And you need glutathione to kind of clear that away. It kind of neutralizes that hydrogen peroxide. If you don't have enough glutathione, then that hydrogen peroxide will start to also attack the thyroid cells and then cause these Tpo antibodies to go up, right?
Yeah.
And glutathione, I mean, there's so much we can talk about glutathione, but it brings us back to one of the other cofactors, selenium, that we need for thyroid function, because selenium is also needed to kind of like
recycle and regenerate that glutathione. Yeah,
because every time we use glutathione to take care of this hydrogen peroxide, we've used it up, we can actually reduce it back so that we can reuse it continuously over and over again, but we need selenium for that. So when you start getting deficient in the nutrients you need for thyroid, you can actually inadvertently also create this issue where your body doesn't have the capability to clear away the stuff that's attacking that thyroid at the same time, isn't it?
Yeah. That's where methylation comes in as well, and women with methylation issues, you'll always see they have thyroid issues. And that's a big one we can look at when we look at blood tests. We obviously want to look at the thyroid panel, but there are other markers that we can look at that can give us a really good indication that there could be issues with the thyroid, and one of them is those methylation type markers, so your B12s, your folates, even your white cell count, your neutrophils, that they can all give indications on how well you're methylating, and if you're undermethylating, then of course you're going to have thyroid issues as well.
Absolutely.
So, yeah.
No, I'm sorry, I'm going to have to sneak a bit of biochemistry into it. But NADPH is a big one, right? So NADPH is
as soon as you start talking about biochemistry, the green becomes huge.
Isn't it?
I'm sorry, I've got a geek out. So NADPH, it's a redox molecule, but it's needed for, when we were talking about the thyroid hormone, T4, T3 conversions and T3, we need deiodinase enzymes, right? D1, D2, D3, I think. But a lot of those processes of converting iodine to iodide and all of those biochemical processes of also converting T4 and T3 requires that NADPH as a factor. You need to use a lot of that to kind of make all these processes work. But that same cofactor is also needed for glutathione recycling. So you can see like how you really need to kind of support a lot of the mechanisms. And glutathione was one of the ones that I just found that the thyroid really loves glutathione, right? It just loves that. And our bodies make this stuff. I mean, we make glutathione by using 3 amino acids, glycine, glutamic acid, and cysteine, which we get from animal proteins. I think cysteine we can't get from plant proteins from memory. It's only from animal proteins. So again, we come down to digestion, and then the minerals like selenium and good mitochondrial function to make that NADPH and all of that stuff. So all of this to kind of like, get that glutathione going. I've had my geek out. I'm happy.
It's funny, even when you talk about we need those particular amino acids, how often do we see women on plant-based diets that have been on them for a long time that don't understand that those amino acid profile, the amino acid profile that they need, and then they're ending up with thyroid issues? Is it because they're undermethylating, because they're not getting those amino acids that they actually need? So that's always a really big one that we see as well.
Yeah.
And if you are on that plant-based diet, supplementing often with amino acids is critical, isn't it?
Important.
So important. So,
and then we kind of vaguely just touched on it a little bit in the beginning. Mercury and the thyroid, right? I mean, that's a big one.
And there's a lot of research. I don't have any specific data in front of me that if in terms of that selenium deficiency as well, if you're someone that already has that selenium deficiency, you're much more susceptible to that mercury toxicity, aren't you?
Well, and why is that? Because selenium is a heavy metal detoxer as well.
Exactly.
So, I think it binds directly, right? Doesn't it bind directly to mercury? So, because I see a lot of, not so much these days anymore, because I think, it's us older demographic that used to have the amalgam fillings, the silver fillings in the mouth. And I used to see so many thyroid issues with women who have had like a mouthful of amalgams.
And also on that, a lot of women, particularly, men and women we see, they want to get them taken out. And so then there again can be an issue. So you want to be really careful if you are thinking of getting your amalgam fillings taken out, because once they start to break them down, that's when you can release that mercury.
Absolutely,
so you want to make sure you're going to someone that really knows what they're doing.
And then think about heavy metals and toxins. I don't want to go into that, but where do they find themselves lodged in tissues around the body as well? So this is where if you've got that chronic exposure to certain heavy metals, say mercury or other toxins, they're things that are, as you said, Nick, once you start to play with those and start to move those about, you've got to make sure that you've got a really comprehensive detoxification protocol in place that's been guided by...
Because you don't want to just mobilize heavy metals. You need to be able to know that it's being bound and that it's being moved out of the body. So definitely use a dentist who knows what they're doing, like, usually what biological dentists or what have you, they need to use the kind of protective gear. In my opinion, I'm sure in your opinion as well, there needs to also be nutritional measures taken around that, which you need to see someone like you guys to help there. But yeah, mercury is a gas, it's... I remember, when I was studying, like we all had to make medicines, right? Now my job was to do the mercury. Right? So I just remember they said, you've got to be really careful with this stuff. And I probably shouldn't say this on camera. Wow. But, so you have to kind of measure 0.1 gram of mercury. And mercury, if you've ever seen, it's a droplet, right? And it just swishes from one side to the other. And so to try and break up it into smaller droplets to measure 0.1 milligram, it's a very hard task.
Is this from like chemistry? Because I'm like, I don't ever remember touching mercury when I was studying.
This is in South Africa, so it's more like medicine that we studied back then, right? And I just remembered everyone else had the easy stuff, like phosphorus and powders, and I couldn't get like this thing. And I think eventually it fell on the floor, and I just said, and I'm like, oh, that's not good. And I was just checking that no one saw what I did, right? But it's very toxic stuff. Jokes aside, I was very young back then. Now that I know, I survived it. But it is. It's like, when you start filling with it and breaking it out of the teeth, you got to work with someone who really knows what they're doing.
Yeah, definitely.
For sure.
Yeah. So I guess we can look at talking about heavy metals and chemicals in general, environmental chemicals, and how they affect thyroid function, and that's one of the most common causes of thyroid function is those environmental chemicals. Also, body care products and things like that as well. It's a lot of chemicals to be putting on your body, and that can have a big impact on thyroid function as well.
Yeah, and I'm just thinking now, if you put creams and stuff.
Yeah, and women put perfume on their throat.
Perfume,
right over your thyroid as well. So there's
that's a good point. I never really thought about that.
Yeah, so that's exactly it. We know the things that, as we were speaking about, certain foods and things that can impact in terms of thyroid function, that iodine uptake, certain nutrient uptake. But once again, it comes back to the modern woman. She's faced with all of these environmental toxins and chemicals every single day. And where can we start to once again reduce that? Because if that is then the burden, so we remove the gluten, we do the full thyroid panel, we're doing all of these things, and then she's still putting hundreds and hundreds of chemicals on her body every day. Is that something that we've got to consider as well?
Yeah. Because I've always felt like the thyroid, it's such a delicate little gland.
It is,
and I've always thought that it, found it just absorbs a lot of the junk that goes into the body.
It's a chemical sensing gland.
So,
and it'll adjust itself depending on what chemicals are coming in. Exactly. So, that's something that we really need to be mindful of.
Absolutely. One of the other things, I don't know if we want to go too much detail into it, but there is also some hormonal connections, to thyroid as well. I know that one of the functions of T3 is to sensitize catecholamine hormones. Now, catecholamine hormones are estrogen and adrenaline. So all to do with energy and female sexual health. And there's probably other areas as well where this will play a huge role. Like I'm just thinking even in terms of stress, stress will kind of put a pressure on that COMT enzyme that has to do with estrogen detoxification, and then you also get the reverse T3. But I think you said something interesting, Nick, about, you brought something interesting up about estrogen and I can't remember what context it was.
I think we were talking about estrogen, even dominance, and that dominance doesn't necessarily mean estrogen excess. It's just an imbalance of your progesterone and your estrogen. So if you're producing too much estrogen or it's out of balance, your liver will actually produce thyroid binding globulin to actually slow down the thyroid, if it detects high levels of estrogen. So how often do we see women with estrogen dominance that have thyroid issues?
Yes.
So they can go hand in hand as well.
Yeah.
So,
and what about excess testosterone? So your PCOS type women.
Yes.
Where do we start to see the thyroid fit in there as well? So looking at that insulin that you were touching on before.
Sex binding hormone globulin.
Exactly. So the sex hormone binding globulin. And I know we were briefly touching on things, nutrients as well, in regards to supporting that free fatty acids as well around the thyroid as well, Elizma. So carnitine. So particularly with those PCOS women, do we use things like carnitine to help support that cascade? So we're not constantly in that sugar burning, glucose burning, and we're supporting that fat burning approach as well.
Absolutely.
And Elizma busted the best myth I've heard in a long time about carnitine and thyroid.
Yes, exactly. Because we were talking about that, weren't we, Nick? We were saying, well, do we need carnitine in thyroid conditions?
Yeah,
and
because
of course,
there is a school of thought that carnitine can actually inhibit thyroid function or suppress thyroid function. But Elizma totally debunked that, which was amazing.
Well, at least from one mechanism.
I loved it.
Yeah, so to kind of, you know, when you have like, and it goes a little bit back down to the starvation. So whenever you have, we've got to kind of like think of how cells get energy. So when you're starving yourself, you start to break down a whole bunch of fats into small fatty acids. Now, as long as you burn these free fatty acids, it's fine because you're using it for energy. But let's say you're not really doing any exercise, you're just kind of starving, or cellular starvation, I should say. You'll get, start breaking down fat into smaller free fatty acids. Insulin resistance will also cause that to happen, like a large amount of free fatty acids. But because you're still eating carbs and sugar and stuff, your cells are full of sugar and it doesn't need more energy. So it doesn't want to get the fats to get into the cell. So they'll just kind of like drift around in the bloodstream. But what free fatty acids can do, if you're not burning that all for energy, they can actually interfere with the binding of T4 thyroxine thyroid hormone to the thyroid binding globulin hormone, which can then start to really mess around with your thyroid hormones. And one of the key nutrients to get those free fatty acids into the cell to be burned for energy is carnitine. Another one is FAD. So FAD is the active form of riboflavin or vitamin B2, and that's also a key nutrient to break down fats, to burn fats. I think specifically your very low chain, your very low chain fatty acids. And the interesting thing again is you need T4 to convert that riboflavin into FAD to help with that fat burning, to help the thyroid work better. So I just love how the body just, you can go in circles and everything needs something else to work, right? And it all comes back to the beginning. So sometimes our job is to figure out where in that whole cascade has stuff gone wrong, which then screws up the whole thing, doesn't it?
That's what I love about natural medicine or being a health practitioner, because I love a good mystery, and I love to just get to the bottom. I was either going to be a private investigator or a naturopath. So I sort of bring in my private investigator skills. But it's all about putting the pieces of the puzzle together, and you look at it. I might probably sound like a bit of crazy as I say this out loud, but when I'm talking to somebody, I get a picture of their system.
Yes,
in my head,
and
start to pull it all apart and come back to what could be the driving factor, and I really enjoy it.
Yeah,
it's just really fun. It's like solving that mystery.
It is.
Yeah.
And that's kind of like where it becomes a bit of a shame that a lot of experts out there, or very good practitioners, but a lot of them just look at the thyroid as the thyroid, right? Or anything like that. The liver as the liver, the adrenals as the adrenals. And they forget that, especially in terms of the thyroid, it's the HPTA axis, isn't it? It's the hypothalamus, pituitary gland, thyroid, adrenal axis. You got to look at that whole thing, and then even beyond that to infections, stress, toxins, that kind of stuff.
And that's, I know as practitioners, it's the classic thyroid protocols. You can almost throw them out the window, can't we? Like it's so often now you can't ever put someone in that box and say, we'll just treat you with the nutrients and these sorts of things and you'll be fine and see you on your way. It's coming back to treating the person, and I think that's where that complexity of people's cases and their case history and the symptoms that they have now, it is, like you said, Nick and Elizma, it's that investigation, it's the detecting that we have to do, and we have to treat that person. And that's even where, if we tie that in back to with thyroid. So we can do all of the blood testing and all of those sorts of things and still not see anything. And it comes back to, I think you touched on, Elizma, the concept of cellular hyperthyroidism.
Yeah.
So when everything else is exhausted, that we can't see any of imbalances, why else now is then the thyroid still sensitive? Why is there still things that are affecting that function overall?
Absolutely. Yeah. And I think, if I had to kind of like simplify it, and I want to get into a little bit more in the testing in a bit, but if I had to kind of simplify it, for me is liver and gut really plays, apart from that HPTA axis we just talked about, because the liver is where a lot of these hormones are being made, the SHBG, TBG hormones, also where estrogen detoxification takes place, insulin resistance gets regulated there, and all of these things affect the thyroid, as well as detoxification of heavy metals and stuff that affects the thyroid, and then the gut, where you need the absorption of the nutrients, the conversion of the iodine, the gallbladder function, all that kind of stuff. So that's probably a bit of a simplification, but I like to kind of think of it like that.
Oh, it is. Well, how often do we see high cholesterol when we're looking at thyroid issues?
Yeah.
And there's a lot of times it's not correlated, particularly in the medical profession, not bagging them at all, but we always see that cholesterol go up. Always, the LDL particularly.
We seem to say a lot that we're not bagging the medical profession. We might just have to put a disclaimer at the bottom of all of this. Just put a disclaimer down to cover our backsides.
We're being nice about it though, aren't we, Guy?
Yeah. I think so.
Yeah.
We're inviting discussion.
Exactly. We're doing our job.
Debate.
Exactly.
That's right. Right, so let's look a bit at testing. All right, so as we've already discussed, when you go to through the general medical field, they probably just measure TSH. We already know that that's not enough. So if someone wanted to kind of like get a good idea of their thyroid function, what would be the markers that we would suggest that get to be checked out?
Yeah, so the TSH obviously, but then free T3, free T4, and this is where the free hormone is really important to test, and that's often not tested as well. Your reverse T3, your thyroid antibodies, thyroid TBG, so the binding globulin. Is there anything else I missed?
Yeah, the TPO and the TRAPS, I think you said.
Yeah.
So that would be a very comprehensive thyroid panel, and we're talking now about blood tests.
Yes.
But then we can also do nutrient testing, like you mentioned, the zinc and selenium red blood cell.
That's it. The vitamin D, definitely. Yeah. Do your iron studies.
Definitely iron studies.
Oh, yes, definitely iron studies.
Yeah, B12, folate.
B12, folate.
B12, folate,
your whites your immune markers as well, because that can be that can come into play as well.
And also, if even just if someone hasn't had that recognised yet, do your HLA as well for looking into potential celiac genes.
Yeah.
If you do have them, it might be worthwhile testing them.
One.
Yeah.
I'm wondering if there's anything else. I thought I had a list.
Of
lipid
thinking.
markers as well. You want to look at your lipid markers.
Yeah, definitely lipid markers, Nick.
We when I do pathology testing, I order a lot. I just try and get as much as I can, and then we sort of cross our fingers and see what comes back.
Exactly.
Yeah. So some of the other things, this is now going a little bit more beyond the thyroid, but more at looking at causes, potential causes for thyroid dysfunction, because now you know what's happening with the thyroid, but now you need to figure out, okay, this is what the thyroid's doing, but what is pushing this? So I've got things here like we spoke about this one for the 8-OHDG, which is the marker for oxidative DNA damage, to see if there's something that's driving some kind of oxidative stress. Ferritin, which will be in the iron studies.
Yes, that's an interesting one. It tells us a lot.
That does.
Yes.
Good inflammatory marker, isn't it?
It is.
Not just iron.
Yep. Yeah.
Homocysteine I've got here as well as something potentially to check for. It gives us a bit of a good idea also about glutathione production and things like that as well. And a few others, but I think that's kind of like pretty much very comprehensive in terms of...
Yeah. So there's, as we can see, there's so much that can go into comprehensively testing thyroid function and the other markers that we need to look at. So it's not just enough to do TSH. I think we can throw that out the window pretty quickly.
So. Yeah. And look, I've myself, we've had our thyroids tested, and I don't know about you guys, but I just did it myself, paid for it, so that I could get all the information that I needed. And
I found even if we go into functional testing, as we all know, starting with the gut, do we need to do a comprehensive stool analysis with these clients as well?
Or organic acid test.
Organic acid test, Dutch test. Dutch doesn't directly test thyroid, but we often see
indirectly.
So, and I love that, because if we do the Dutch test and then we start to see, well, actually, is your thyroid being the thing that's controlling a lot of this? Let's get a full thyroid profile and go from there as well. So,
because iodine is also involved in estrogen detoxification, isn't it?
Exactly.
Yeah. So sometimes you can look at the estrogen patterns that could indicate whether there's potential iodine deficiency, and if there is iodine deficiency, well, it's going to affect your thyroid big time.
Yeah.
Anything we missed out, girls?
Gee, I feel like there was so much more.
I feel like there is.
I know.
I mean, the thyroid is, I just love speaking about it.
And I think it's been so comprehensive that we've probably covered a lot.
Probably covered a lot. I guess one thing we didn't touch on, and that we see a lot, I know, in practice, is postpartum thyroid, autoimmune thyroid.
Yes.
It's a really big one.
Actually, I'm glad you're touching on the pregnancy, but I'll let you first finish what you wanted to say.
That's okay. I don't know, now you've thrown me completely. It's very common to see it post pregnancy. Usually within the 3 to 9 months after you've had your baby, we can see that autoimmune thyroid come on. It can be, your immunity is suppressed when you're pregnant, obviously, so that you don't reject the fetus. And then obviously when you've had the baby, your that bounce back can cause a little bit of a dysfunction in that immunity as well. So that can be an issue, but that's a really common thing that we see. And quite also that's quite interesting is a lot of postpartum depression. There's a very large percentage of women that have thyroid antibodies. So there's a connection there as well. Yeah.
Very interesting. Well, I know that in terms of mine goes more not necessarily postpartum, but the importance of thyroid hormone in the beginning of pregnancy, because the fetus can't make thyroid hormone, and because they're growing, cells are replicating, there's huge metabolic demands, right? And so it'll use mum's thyroid hormone to get all of that stuff going, and it is one of the most common reasons for miscarriage is not having adequate T4 or thyroid function in the early stages of pregnancy, right?
Exactly right.
Stillbirth can be a factor as well.
Yes.
Obviously, infertility before you even can get pregnant. A lot of women struggle with infertility with thyroid issues as well.
But that's why, if I have anyone who falls pregnant, I always recommend that they get their thyroid panel checked with their first blood. When they do all the iron studies.
That's
and
it.
things like that.
Well, preconception then, if we even, in terms of planning that pregnancy, doing a thyroid profile before you even, start to do that pregnancy planning, 3-6 months out. 3 is the minimum that we typically go off in terms of working on those hormones. So, and that's where those nutrients, once again, so even through pregnancy, are they deficient in some way in selenium? Are they deficient in iodine? Are they deficient in zinc? So, if you come through that pregnancy on the other side, the postpartum, if they're already clinically deficient in these nutrients, of course we start to see that potential for any sort of postpartum thyroiditis, potential Hashimoto's, anything like that. So, it's really, really important.
All right, anything else?
I'm going through.
I think we've covered a lot.
I think we have covered a lot. I mean, we can almost write a book about all of the stuff that we've got here.
Yeah.
So, let's wrap it up. So, main things to take away is foundations. Make sure you're not deficient in any nutrients. Digestion needs to work here. Good nutritional intake, macronutrients, all of that kind of stuff.
Absolutely.
Remove any interferences, stress, which could be stress over training, infections, all of that kind of things. And usually, most of the time, when you do those two things, that's pretty much all you have to do. And if there's if it gets a little bit more complicated, well, then you work with someone who can look at the body as a whole and not just focus on one gland and treat it as such.
Exactly.
And I guess my sage advice would also be, look, if you can, hold out on medication for as long as possible and first try the common sense routes and the fundamentals. That would definitely be my advice, because it's very hard to get off these medications once you start on them.
It is.
Absolutely, Elizma. Absolutely. That's the thing. The thyroid gland is a small gland, but it is a powerhouse at the end of the day. And as we've touched on throughout this podcast, it controls so many different functions. So I think, as you said, Elizma, try and start from the ground up, as we always do, work on those foundations. But then if you're questioning that, if you're thinking there's something still not right, I don't know if it's my thyroid, seek that professional support and find someone that's willing to go to those lengths to test appropriately and comprehensively so that we're getting to those underlying causes.
Yeah, I agree with you, Dan. That would be my last piece of advice is don't take no for an answer. If you're seeing a GP and they're saying no, everything's fine, it looks fine, and you know you don't feel fine, then just keep going until you can get the answers you need, you know, whether you see a health practitioner or functional GP or anything like that, but just make sure you get those markers tested so you can see what's actually going on.
Yeah, absolutely.
Yeah.
All right, I think that wraps it up for us.
Yeah, it does.
Any questions, you know, shoot through and we'll try and answer as best as we can. Thanks, girls. It was a very fun talk.
It was, yeah.
Until next time.
Until next time.
All right.
Bye, guys.
Bye.